Hey everyone, and welcome back to the channel. Today, we're re-tackling a topic that can feel super intimidating, but is actually incredibly high yield for exams and clinical practice. Heart murmurs. We're going to break it all down, step by step, so you can diagnose murmurs like a pro. Stick around, because by the end of this video, you'll have a systematic approach that makes these questions a breeze. Let's start with the absolute basics. Cardiac auscultation. Where do you even put your stethoscope? There are 4 classic locations you absolutely must know. A great way to remember them is the mnemonic compartment, M, or APTM first. A is for the aortic area, located at the right second intercostal space. P is for the pulmonic area, at the left second intercostal space. T stands for the tricuspid area, found at the left fourth intercostal space, right by the sternal border. And finally, M is for the mitral area, also called the apex. This is at the left fifth intercostal space in the midclavicular line. Memorize APTM roadmap to the heart, telling you exactly which valve you're listening to. This is non-negotiable and foundational for everything that follows. It might seem impossible, but it's all about pattern recognition. Let's walk through an example. Let's break it down. First, the timing is systolic. Second, the location is the apex. Remember, our APTM mnemonic, the apex corresponds to the mitral valve. So, we have a systolic murmur at the mitral valve. Now, is it mitral stenosis or mitral regurgitation? To figure this out, we need a quick review of valve physiology. Think about what the heart is doing. During diastole, the heart is relaxing and filling up. Blood flows from the atria into the ventricles, so the mitral and tricuspid valves are open. During systole, the heart is contracting and ejecting blood. The ventricles squeeze blood out into the aorta and pulmonary artery. So the aortic and pulmonic valves are open, while the mitral and tricuspid valves slam shut. Back to our example. We have a systolic murmur at the mitral valve. Since the mitral valve is supposed to be closed during systole, a murmur here means blood is flowing the wrong way. It's leaking or regurgitating backward from the left ventricle into the left atrium. So, the correct answer is mitral regurgitation. This leads us to a core rule you can memorize. Diastolic murmurs are the opposite. Stenosis of the mitral or tricuspid valves, or regurgitation of the aortic or pulmonic valves. Another crucial rule for exams involves breathing. How does inspiration and expiration affect murmurs? You can remember this as rinspiration for right and L-expiration for left. When you take a deep breath in, you increase blood return to the right side of the heart, making right-sided murmurs like tricuspid regurgitation louder. Don't overthink this one, just memorize it. Preload is simply the volume of blood returning to the heart, stretching the ventricles at the end of diastole. You can increase preload with maneuvers like squatting or raising the patient's legs. This brings more blood back to the heart. For most murmurs, more blood means more turbulence, so the murmur gets louder. But there are 2 very important exceptions: hypertrophic obstructive cardiomyopathy, or HOCM, and mitral valve prolapse, or MVP. These 2 murmurs actually get softer with increased preload. We'll explain why in a moment. Conversely, you can decrease preload with the Valsalva maneuver, which is when you bear down like you're trying to have a bowel movement. This decreases blood return to the heart. As you'd expect, most murmurs get softer. But our two exceptions, HOCM and MVP, get louder. This is a key differentiating feature on exams. So why is HOCM different? In HOCM, the septum of the heart is abnormally thick, and it can block the outflow tract of the left ventricle. When the ventricle is full of blood, meaning high preload, the blood pushes that thick septum out of the way, reducing the obstruction. So, more blood, less obstruction, softer murmur. The classic triad of symptoms is SAD, syncope, angina, and dyspnea. Think of an old patient who is sad. Next is mitral regurgitation. This is a holosystolic or pansystolic murmur, meaning it lasts throughout it's loudest at the apex and radiates to the axilla or the armpit. It's often associated with a history of rheumatic fever. Then we have tricuspid regurgitation. This is also a holosystolic murmur, but it's loudest at the left lower sternal border. The key feature here is that it gets louder with inspiration because it's a right-sided murmur. This is classically associated with drug use, which can lead to endocarditis affecting the tricuspid valve. The absolute highest yield buzzword for mitral stenosis is an opening snap. This is a sharp sound heard right after S2, as the stiff mitral valve is forced open. It follows the same rules as HOCM for maneuvers. It gets louder with Valsalva and softer with squatting. So, to wrap it all up, let's review a final exam tip. If all the physiology and maneuvers fail you on test day, rely on the buzzwords. They are there for a reason and can save you precious points. If the murmur radiates to the carotids, it's aortic stenosis. By combining the location, timing, maneuvers, and these classic buzzwords, you'll be able to confidently answer any heart murmur question that comes your way.